Welcome to Medical Journal Club. In the next few minutes, we'll dissect the BRIDGE-TNK trial, the NEJM study that claims Tenecteplase before thrombectomy finally beats thrombectomy alone for large vessel occlusion stroke. Is this the long-awaited game-changer, or another statistical mirage? Let's find out. Large vessel strokes cripple millions. Endovascular thrombectomy, EVT, reverses many, yet debate rages over bridging for thrombolysis beforehand. 6 alteplase-heavy trials showed no clear benefit. Only 2% of participants ever received Tenecteplase. Tenecteplase, with its single bolus, longer half-life and tighter fibrin targeting, promised faster, cleaner clot lysis, but lacked randomized data against direct EVT. BRIDGE-TNK fills that evidence gap and has the stroke world buzzing. Picture alteplase's sleeker cousin. Tenecteplase is TPA engineered for single 4 bolus, 0. 25 mg per kilogram, max 25 mg, versus a 1-hour infusion, greater fibrin specificity, meaning more clot, less systemic fibrinolysis, and 5-fold longer plasma half-life, giving it longer to work. These aren't just theoretical advantages. Previous head-to-head trials like BRIDGE-TNK showed Tenecteplase achieving higher early recanalization rates than alteplase. So here's the central question that BRIDGE-TNK set out to answer. Does Tenecteplase before thrombectomy improve outcomes compared to thrombectomy alone? The timing couldn't be more relevant. While the stroke community has been moving toward Tenecteplase based on its practical advantages, we lacked definitive evidence for its role in bridging therapy. BRIDGE-TNK aimed to fill this critical evidence gap. BRIDGE-TNK was a multi-center, open-label randomized controlled trial with blinded endpoint assessment. This was conducted across 39 hospitals in China, enrolling 550 patients with acute ischemic stroke from large vessel occlusions presenting within 4-5 hours. The trial enrolled adults with confirmed large vessel occlusions who were eligible for 4 thrombolysis per local guidelines. Participants were randomized 1:1 to either Tenecteplase plus thrombectomy or thrombectomy alone. Median age was 70 years, 58% were male, median NHSS was 16 and pre-stroke MRS was 0. Time from symptom onset to randomization was 160 to 168 minutes. Crucially, the median time from Tenecteplase to thrombectomy puncture was just 16 minutes. Primary endpoint was functional independence at 90 days, defined as modified Rankin scale 0 to 2. Essentially, can these patients live independently? Secondary outcomes included excellent outcomes, MRS 0 to 1, independent ambulation, MRS 0 to 3, successful reperfusion before and after thrombectomy using the TISI scale, first-pass reperfusion rates, and safety outcomes including 48-hour symptomatic intracranial hemorrhage and 90-day mortality. Alright, let's dig into the numbers. Our primary endpoint, functional independence at 90 days, was reached by 52.9% of the Tenecteplase plus thrombectomy group versus 44.1% in the thrombectomy-only arm. That's an 8% absolute improvement, or a risk ratio of 1:18 with a p-value of 0. In plain English, for every 11 to 12 patients you bridge with Tenecteplase, you get 1 extra patient who can live independently at 3 months. But there's more. Before our interventionalists even got to work, 1% of patients in the Tenecteplase arm had reopened vessels on their first angiogram, compared to just 1% without Tenecteplase. That 5-fold difference suggests Tenecteplase was actually dissolving clots before the interventionalist even got to the angio suite. But here's what's puzzling. Successful reperfusion after thrombectomy was actually slightly higher in the thrombectomy alone group, 94.1% versus 91%. This counterintuitive finding raises important questions about the mechanism of benefit. Of course, every upside has a downside. Symptomatic intracranial hemorrhage occurred in 8.5% of the Tenecteplase group versus 6.7% in controls, numerically higher, but not statistically significant. 90-day mortality trended up as well, 22.3% versus So yes, adding a powerful clot buster comes with a bit more bleeding risk, though we can't say for sure it's more dangerous. It's that classic trade-off in stroke thrombolysis. Now, what did this trial get right? First, it's the largest RCT yet on Tenecteplase bridging 550 patients across 39 high-volume Chinese centers. Second, outcomes were adjudicated blindly, so even though the trial was open-label, the people scoring the misses didn't know which treatment each patient got. Third, they nailed really fast workflows. Our median lysis to puncture time was just 16 minutes, showing what's possible in optimized stroke networks. And finally, they answered a question we'd only had hints about before. Does Tenecteplase truly move the needle on patient-centered outcomes? Here's the first clear yes. On to the caveats. First, open-label design. The teams knew who got Tenecteplase, which could subtly influence care. Second, this was an all-Chinese cohort. Genetic, epidemiologic, and system factors might limit how well these results translate to, say, North America or Europe. Third, the trial was powered expecting a 13% benefit but only saw 8%, so the effect size was smaller than hoped. Couple that with a p-value sitting right at 0.04, and you see why some call it a fragile finding. I see 3 big takeaways for practice. 1. If you run a high-efficiency stroke program with sub-20-minute lysis to puncture, consider Tenecteplase bridging. You could boost independence rates by nearly 9%. 2. Be mindful of your local workflow. If your door-to-puncture or transfer times are longer, the benefit may shrink. And 3. Keep an eye on upcoming trials. Resilient BRIDGE-TNK in Brazil tests the same question in a different population. BRIDGE-TNK Extend will look at 5 to 24-hour windows, tackling late presenters. We also need cost-effectiveness analyses. Tenecteplase costs more than Alteplase in many markets. So while this is promising, it's not yet a universal green light. Let's wrap up. BRIDGE-TNK is the first RCT to prove Tenecteplase bridging beats direct thrombectomy for large vessel occlusion strokes, 1 extra independent survivor per dozen treated. But the bleeding signals, the geographic limitation, and the p-value fragility mean it's compelling, not conclusive. What's your take on these results? Are you convinced by the efficacy data, or do the limitations give you pause? Share your thoughts in the comments below. If you found this analysis valuable, please hit that like button and subscribe for more evidence-based medicine content. Thanks for joining me in the Medical Journal Club, and I'll see you in the next video.